Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
My guest today is Dr. Jan Kerschot. Dr. Kerschot was kind enough to come on the show with James Ferry back in Season 3. That was Season 3, Episode 8, if y'all want to go back to that. In today's discussion, we talk about fascia and the fact that fascia is not only connective tissue, but it's a highly innervated tissue that has some really interesting properties that oftentimes we never really think about. I really enjoyed this conversation with Dr. Kerschot, and I know you will too, because it's going to expand your concept of connective tissue and maybe help you find some pain generators that you might overlook otherwise. So without any further introduction, please enjoy this conversation that I have with Dr. Jan Kerschot. All right, Dr. Jan Kerschot, thank you for...
Hello, Steve. How about it?
Yeah, thank you for coming on the show again. So I just want to tell everybody that if they like what they're hearing today, which I know they will, they're going to want to go back and listen to you. And that was on Season 3, Episode 8, where we talked a lot about hydrodissection. And I got a lot of interest from that. So I know a lot of people are going to really resonate with your message today.
Yes.
In case there's a few people, which I'm sure there are, who didn't dial in on that episode, why don't you tell everybody your background, what you do, where you are, and then we'll go into the discussion.
My pleasure, Stephen. Well, let me say that I am a physician practicing in Belgium, in Europe, since 1986. I graduated in 1986. My father was a family physician. I have two brothers who are physicians as well, but I was like a bit of the special guy in the family. And it started as a patient. When I was in my fourth year of medical school, like 21 or so, I suffered from low back pain myself. I would now describe it as pseudosciatica, L4, L5, going to my right groin, and very annoying. Like sitting for a few hours was really awful for me. And we were sitting at the table, and I asked my father, who was a family physician at the time, what should I do about my back? It's still hurting. And he said, oh, I will send you to my colleague and he will give you a shot. And I asked him, so what is going to inject me then? And he said, of course he's going to inject you steroids. What else do you want? What else do you expect? Really?
Right.
And I said to him, but we just learned at university the 10 major side effects of steroid injections. Like you can have your Achilles tendon ruptured, you can have cartilage problems after injection, and so forth. It was even a typical examination question, exam question. Mm-hmm. And so I still knew them by heart, and I said, I don't want this thing in my body. That was my point. And then he said, well, there is a doctor, not so like half an hour drive from here, and many of my patients go there for German injections. I don't know what they are, but maybe you could try that. Maybe that's something for you. That's what it said. So I drove there and first went to see what he was doing. And he was doing neural therapy, which is a German injection technique using procaine 1% mainly. And I thought, well, that's not cortisone. It sounds good to me. And he promised me that he would be able to help me with some sessions. And he used quite long needles at the time to give paravertebral injection on the right side, on L4, L5. And after maybe 5 or 6 sessions, I was about 80% better. Not 100%, but 80%. And I thought, this is interesting. And I thought to myself, and driving back home, And when in a few years I will be graduated as a family physician, and I want to specialize in pain medicine, will I give steroid injections to my patients when they sit in my office while I refuse them? That was like a sort of mental issue, a sort of, I was struggling with that mentally, emotionally. So I said to him, to the doctor, can I learn this from you? And he said, yes, you can come and see me practicing this in my office. He had a lot of patients every day, amazing visit practice. People coming from all over the country, driving sometimes 1 or 2 hours to get inside the office for 10 minutes and drive back. And then he said to me, you have to come to Germany to follow the neurotherapy course, which I did. That was 1984. I was still a medical student. And then I learned about the neurotherapy, followed the course, saw a few of these other guys. And when I graduated as a family physician, my father passed away in between. I started to do a general practice, including the German neurotherapy. And after already a few months, the majority of patients coming in to see me were all those patients who want those injections. Mm-hmm. And the other ones, I was less interested. Prescribing antibiotics, prescribing pain tablets, it's okay, but it's not really like a passion for me. So I said, after 4 years, I'm going to focus only on these new type of injections. And I call them non-steroidal injections. Mainly Procaine, also some other German products. And later on, I learned about French mesotherapy, which is also injections. Trigger point therapy from the Americans. I learned about prolotherapy. I learned about different techniques. And I started to combine all those. And over the years, one of my favorites was an article by a Korean doctor in 1997 who did a clinical study comparing 3 products for myofascial trigger point injections. The first was the Procaine or it was lidocaine 1%. The second one was dextrose 5%. And the third one was a sodium chloride of 9%, I think. And he compared these 3, and I would expect that the local anesthetic would be the best, because that's the one that I use. Right. And he found out that the dextrose was better. So this was like, for me, but wow. So I started to use more and more dextrose 5%. And I noticed that also my patients said, these injections that you gave last time, or over the last few sessions, give me much better results than the ones you used before. So after a few years, I started to give more and more sugar water 5% injections, and less and less of the other products like the lidocaine and the Procaine. And let's say that I was a bit reluctant to share my experiences with the outside world, my colleagues, because I thought that people would laugh at me. Sugar water 5%. I mean, this is 95% water. Imagine. Right. And then you treat chronic pain patients, neuropathic pains, myofascial pain, amazing, difficult patients who went maybe to surgery without results, and we can help them. Or were scheduled to have surgery, and after 4 or 5 sessions, they just quit the surgery, and they just went on without any medication or without any surgery. And for me, it was in the beginning like, maybe it's a placebo effect, or maybe I'm imagining it. But then I found several studies, especially from Asia, where randomized control trials were done, especially for carpal tunnel syndrome, ultrasound-guided injections. Professor Stanley Lam, for example, from Hong Kong, is the expert there. And I've been in touch with him, by the way, in the meantime. And he published these studies and found, for example, one study compared the dextrose 5% with steroids for carpal tunnel syndrome. And after 6 months, the outcome was the same. But the dextrose has no side effects. The steroids have plenty of side effects.
Right.
So I thought, and for me, it was like a revelation. I said, I'm not the only one having these experiences. And now I have found someone who really scientifically has proved to all of us that it really works. And he's not the only one. There are 4 or 5, there are a few Americans as well. Epidural injections. And Smigel is her name again, from Hawaii, I think, the doctor. I met her once in a training. There's an Indian doctor, Nitin Pandey, who wrote the foreword of my book in India. He did a double-blind study on dextrose 5% on epidural injections. So again, great news. But here in Europe and also within the States, most people just look the other way. The doctors don't seem to be interested. And it's amazing because these studies are really high level. And I was a bit disappointed that there was not so much interest. I tried in a local university just nearby here where I studied, and I know a few doctors there. Can you just don't do this instead of steroids? If I ask, I send the patient to you for an epidural, but I didn't get any answer yet. So they are not very interested so far. But my goal is not only to sort of convince physicians, sports doctors, family physicians, orthopedic surgeons to use dextrose 5%, or we use glucose 5% in Europe instead of the steroids. But I also want to spread this message in countries with low income patients or areas with low income patients. Because I've been teaching injection techniques for more than 50 years worldwide. I've been in Russia, South Africa, I've been to many, also the United States, Canada, Mexico, and so forth. And in some countries, the doctors are working with patients with a very low income. It's completely different from the United States. There is no insurance coverage and so forth. And for them, my technique, which I call the glucopuncture, is for them a perfect solution. And why is that? You don't need MRI or ultrasound. You only need your two hands and your brains, syringes, and a very inexpensive solution. Dextrose 5%, which is very inexpensive or easy to copy. And because there's no copyright, there is no patent, it's not protected, so to speak, right? So anybody can copy it. And so my plan is with that sort of project to spread the glucopuncture technique in these areas. But this can also be in a country like Belgium or France or England, where you also have areas where doctors have to work with low, let's say, financial support. They don't have enough money to buy an ultrasound machine, which is in some countries quite expensive. And they can start to treat that patients right away. And that is also where the book is made for. And on the back of the book, you see this, maybe you won't see it very well, but there is a logo of the syringe with underneath the hand. And that is the project of the Swede Solution for Medics. It's a soft solution for doctors, sport doctors, or family physicians dealing with patients with pain, neuropathic pain, or fascial pain in low-income countries. And why am I doing this? Because I noticed that, especially in the United States, medicine is very expensive. Don't know in other countries, but it's very expensive. And much more expensive than Europe. And even in Europe, it's more expensive than, say, Russia or most African countries. But they have also a lot of patients in pain, which can be helped. They even don't have the money to go and buy some medication, or PRP is too expensive for them. Hyaluronic acid, beautiful product, too expensive for them. And the main advantage of my technique is that this can be learned quite easily. I am working on an online course to be spread in a few months. I hope I'm working with it for quite a while. But the main thing is that these doctors, without any special equipment, can apply this from the everyday practice. And the diagnosis is mainly based on what we feel, we call it patient-guided injections. We, of course, in America and in Europe, we first do an ultrasound or MRI if we are doubting about it. But in 20%, if you have pain in your shoulder or a tennis elbow or knee, it's mostly just conventional, let's say, musculoskeletal pain syndrome without cancer involved or serious inflammation, because then glucopuncture is not indicated. And what I'm learning these doctors in my courses is, and I've given a few, for example, in Indonesia, I've been speaking about this in Africa, in Russia, is, and they're very happy about that, they can start working with their patients quite quickly, because the injection techniques are very safe. You don't need the ultrasound because we don't go very, very deep. Right. And it's really like the patient says, I have pain here. You're going to look there for the pain post and you're going to inject it there. And the tissues that we inject are the major one now these days is fascia, but we inject a lot in muscle and ligaments and joints as well. Joints mainly knees and shoulders because they are easy accessible without ultrasound. And then the muscles is mainly muscular pain points and muscular trigger points. Same for the ligaments. The ligaments, for example, the supraspinal ligament, the nuchal ligament is very important for whiplash, for example. We also have the ligaments that we check in the lower back, the sacroiliac ligament, and so on. That's, let's say, our target number 2. But the third one, and now the most important one, is fascia. Fascia. When we say fascia in the
we just say fascia.
Fascia, yes, that's the way to explain that. And so the fascia is a very, let's say, under-recognized tissue in our body, and we have it everywhere.
Yeah, let me interrupt you before we get into fascia.
Of course, go ahead.
I mean, you made so many good points already that I just wanted to follow up on a couple of them. One is the cost. And the cost is very beneficial to patients. But I think that is far outweighed by the efficacy and the safety profile of D5W versus steroids or these types of things.
Oh, God.
And so one thing that a lot of physicians that I've encountered over the last 20 or 30 years is they love to inject steroids into and around nerves. And we know that if you inject a steroid, except dexamethasone, I believe is the only one, but if you inject any steroid intravesicularly, you will irreparably damage that fascicle. It's gone. It can't be recovered. And you'll never have that problem with D5W. So the safety profile is extraordinary.
Oh, yes.
And then the other thing I wanted to, we had been doing hydrodissections for a couple of years before I actually encountered your work with glucopuncture. And so we've had a fair amount of experience. Gosh, I think we did that podcast about 6-7 months ago with you. And we've had so many unbelievable results with glucopuncture that when these clinical examples keep coming back to you and reinforcing how well they do, it's pretty self-evident in the clinic. And I think you could read all of the articles, and we're going to talk about your most recent article in a minute, but you can read all these articles, but they pale in comparison to the meaning of when that patient comes back to you and they say, my pain is gone.
Exactly.
Yeah. It's incredible.
This is what touches my heart, what you just said, because I experience this every day since that article in 1997 by these Korean doctors that I also mentioned in my references, in my articles, that I am so happy that these guys have done this comparison between the lidocaine and the dextrose. Otherwise, I would never dare to use the dextrose 5%. Who would inject sugar water 5%? As I said before, it's 95% of water. Right. Can you imagine how could this possibly help? We still have a lot of homework to do, I know, and research, clinical research, but also fundamental research. We think about ATP, we think about TRPV1 and so forth. But for me, I'm more a clinician. I'm not a scientist. I'm not so good in all of that. But I see patients, I have my intuition, my experience of more than 3 decades of injections. And as you say, it's so rewarding for a doctor to have a patient after 1, 2, or 3 sessions saying, my pain was there for 6 months and now I'm playing tennis again.
Right.
And I don't take any painkillers. Right. I mean, that's gold. I mean, that's really so rewarding for you as a doctor that the patient sits in front of you and you know for sure that side effects are like minimum. The ratio, as you just said, between efficacy and side effect is the best you can find. As I'm speaking today, the best I've ever found in my life.
I agree with you. I don't think you can find anything with a wider safety profile.
Exactly.
Than D5W.
Exactly.
So I wanted to talk to you about fascia. And
yes,
before you start, I want to thank you because you're bringing something that we see every day. We cut through it. We disregard it. We don't respect it. It's like you commented in the cadaver lab when you're a medical student. You cut it open and cut it out so that you can get to the organ that you wanted to study and never give it a thought. And the more you publish articles like you've just done here, it makes us think, this fascial system, this connective tissue, is maybe the second largest organ in the body, maybe the largest organ when you take it all into consideration. And then you made the very good point in your article about how densely fascia is innervated with nociceptors, which are, for people that don't know what nociception is, that's pain. That's the nerves that send pain to your brain, to your spinal cord, through your thalamic tracts, into your brain. So nobody really appreciates that. And so I think the discussion that we're going to have today is that it's going to open up some eyes that will make people want to read more about this. And then all of a sudden, they're going to have a different concept of maybe how we need to treat some of these painful conditions. So let's get into fascia and talk about that, because that's going to be the focus of our discussion.
Yes. Let me say that I got to know the fascia gradually. Of course, we all learned about fascia at medical school. Everybody knows what it is. There are two layers. The superficial one, just under the skin. There's a deeper one. Both are connected. It can be important. And then we have the deep fascia around all the organs, right?
Right.
And we thought about it as plastic bags in the old days. And for about 10 years, there has been some clinical research about fascia and its importance. And there are two ways we can look at fascia. The first one you already mentioned is there's an abundance of nociceptors, 10 or maybe even 20 times more than muscle. Wow. Think about the books of Trevor and Simons. Are you familiar with Trevor and Simons? I guess you are. These American doctors who wrote these beautiful 2 books in 2 volumes. I have it somewhere here. It's called myofascial trigger points, myofascial.
Right.
But all the time, you're injecting that procaine or the adrenaline into the muscles. And I've been doing that for years.
Right.
With all sorts of products. First with the procaine, later on with the dextrose, the 5%, for example. And it was more recently that I thought, but if someone, I think you can look at me, and I'm pointing with my shoulder. Someone says, I have pain here, right? We all have it. 1 side, 2 sides. I see several patients like that a week. And I thought, oh, that's the trapezius muscle. And I put my finger on it. I look for the pain point. And then she says, oh, yes, there it is. And then I inject. And I injected into the trapezius muscle, like 1 to 2 centimeters, maybe 3 centimeters deep, like an inch or a bit more, right?
Right.
And I thought, I am doing myofascial therapy, muscular trigger point injections with, for example, procaine or with dextrose of 5%. And it was only recently that I thought, but maybe I'm pushing my thumb on the fascia, which is around that muscle. And maybe the real pain is maybe coming from 90% from the fascia and maybe 10% of the muscle. And so I started to inject more and more superficially just to test. I have sometimes patients who come on a regular basis and then they're good for a while. And I didn't say anything and started to inject fascia. And we use a tangential approach. So instead of injecting perpendicularly, we go that way to have as much as fascia as possible. It's a 2 centimeter needle, that's a bit less than an inch. And you go like 10 degrees or 20 degrees, and you do multiple injections, 4, 5, 6, 7, 8, 10 injections, as I've shown on my, I think also in one of the articles. And what we have seen is that we have even better results with the superficial injections than we have before with the muscle, with the deep muscle injections. So that confirmed for me the whole theory about fascia being extremely important for pain modulation.
Right.
And I'm using it more and more. I'm still using the injections in the muscle. I'm still using the ones in the ligaments. They also have nociceptors. But now my first option is always first treat fascia. And the beautiful thing about this pain modulation with fascia is the fascia is like a network, like a spider web. And the superficial fascia runs everywhere except your nails and your hair. Otherwise, it is everywhere. But it is like a network, literally a network of fibers going in different directions of connective tissue with human fibroblasts inside it, extracellular matrix inside, and lots of nociceptors. And as they are connected, it means that, and I've seen that, a patient says, I have pain here. and repair. And I inject only this part on top, let's say the trapeze, not the deltoid. And I said, I'm going to start with that one. And after 2 or 3 sessions, the patient said, oh, this is better. But this is also better. And I didn't touch it.
Right.
And I did have this once or twice. I started to look at it, repeat it, tested it also with, for example, knee pain, joint pain, so-called hip pain or trochanter pain. And patients sort of said it's like reverse pain for trapezoidals, that we have pain at a distance. And in the old days, it was for me very difficult to explain scientifically that you can inject, for example, the fascia in the neck and your arm is getting better. How can I explain that? Only with the fascia. And then we come to number 2 of the fascia. You've read it in my article, the mechanical part.
Right.
So it's the biomechanics. So you have pain modulation, extremely important for musculoskeletal pain, but also biomechanics, fascia integrity.
Let's talk about a term before you go much deeper so that the audience has a good foundation. Because when they start diving into this literature, they're going to see this word tensegrity.
Yes.
And so
but it's a difficult one.
Yeah.
I need some images. Yes.
Well, if you can explain it a little bit, I think
it's
that
a difficult one.
Yeah.
But I will try. It's not an easy one because there are images which show like a 3-dimensional structure where everything is connected with everyone directly or indirectly. That's the tensegrity model. You can look it up on the internet. You type in tensegrity model, you will get beautiful images. I don't have them here with me, where you can find that everything is connected with everything. But this is not like a, let's say, mental idea or whatever. No, this is really biomechanics, almost like physics.
Right.
And they have made a model with pieces of wood, sticks, and what I call it, cords or cables, small cables, and they're all connected, and the structure stays.
Right.
And that's fascia integrity, right? But this is of enormous importance for, let's say, posture. Am I holding my neck like this, or am I sitting like that? The fascia integrity in the fascias will be talking with each other. They will be connecting. They will put information from one side, from the left part of the neck to the right side, from this part up to the shoulder, even the elbow, you see? And that is for me like a new door opening after the taking point of science. Fascia is like the sort of, there's no magic there, but it's almost like a magical tapestry, like a big carpet, connecting everything with everything. And you put on this ear, and it has an effect on your left elbow. And you put on this ear, it has an effect on your right hand. Like, how can this happen? Right. My brother is a radiologist. He wouldn't believe me. He said, no, there's a hernia here, and the papers go there. But with fascia, we have a new way of explaining the interconnectedness of neck with shoulder, but also with elbow, for example. And so it doesn't have always to be the hernia of the elbow.
So you make a great point. Now, when you start diving into this literature, you'll see that there are mechano-electrical effects within the fascia and also remodeling of fascia where it's abnormally stressed or excessively stressed that then changes the ability for that tissue itself. And that has feedback into the central nervous system without a doubt. I came across an article a month or so ago. I don't have the reference, but it was basically, they were looking at acupuncture placement, needle placement with functional MRIs, and they could definitely see upregulation. I believe it was in the amygdala, deep brain area. I don't quote me on that. I don't have everything at top of mind, but the concept, the take-home important message is that by playing with these fascial lines, or if they want to call them chi, whatever they want to call them, they were getting demonstrable changes on functional MRIs in the brain. So we know that it definitely has an integration with the peripheral nervous system and the central nervous system, which I think is really important, because when you start thinking about that, maybe all that joint pain isn't joint pain. Maybe it's the fascia around it that got stretched and damaged, and the joints hurt. And I've got a patient that I just saw recently, had a very successful arthroscopic meniscectomy. but had chronic pain on one side of his knee. MRIs came back perfectly fine. Everything was great structurally. And guess what? About 7 cc's of D5W right in the area where he complained of the pain. No anesthetic. Within 2 or 3 minutes, 100% pain gone. Now it's incredible, so.
Isn't it beautiful?
Yeah, it's very
beautiful.
But I think that explains a lot that, this tissue that we just discarded was not just a containment system for organs of the body. It is a interconnectedness between every structure, and if it's messed up, then other things are messed up.
Oh, yes. And I have a few remarks on what you just said. You mentioned acupuncture.
Yes.
And I'm not an acupuncturist. And I think some patients are really good with it. I think the needle effect is also works on TRP1 and so forth. But the glucopuncture has nothing to do with acupuncture.
Correct.
There's a bit of a confusion sometimes. It has nothing to do with the acupuncture. Of course, accidentally, we will inject into an acupuncture point, but the doctor who is trained in glucopuncture has no acupuncture or meridians in his head. The patient says, I have pain here in my wrist, and we are going to look there. We might inject in the fascia in the area, or look for specific fascial pain points, or even trigger points at a distance, and we inject them there. Right? And we don't think about anything else.
Well, I was not equating the same, but I was just...
No, they're not the same.
No, they're not the
same.
Just for the audience. But for the audience to understand that if you're able to place an acupuncture needle peripherally and see a change in the brain, something's going on with the mind.
And maybe the fascia has to do with it.
Yes.
Maybe it's not the meridians.
Well, maybe it's the meridians. Maybe the meridians are in the fascia.
I don't know. We will see. Maybe in 10 years, they will tell us.
Right.
Who knows? Then the second point, you mentioned someone with a knee, right? I have patients, and they come and see me and say, oh, for example, the man comes and see me, and after 2 or 3 sessions, his shoulder is better, and he says, oh, my wife, she has problems with her knee, and they're going to operate her in 6 weeks. She has to wait 6 weeks for a new knee, a completely new knee. And he asked me, you can't do anything about it, can you? Because it's bone on bone, right? So-called bone on bone, on MRI or CT, whatever. And I said, bring her in away next week. She comes in, she shows me the MRI and serious, let's say, grade 3 osteoarthritis. Okay, then, and this is interesting, and I hope the audience listens carefully. Suppose that this is the knee, okay? It's my wrist, but suppose this is the knee. And I ask her, where do you have pain? She said, here. Okay. I look at the MRIs again. It's both on the left and on the right side, but there's joint deformation, right? So if the picture corresponds with the clinical picture, she should have equally pain on the medial side and on the lateral side. And I said, only here, only the medial side, and here, no pain. So for me, that's already a big sign. This means that here she has pain, whether it's sort of MRI deformation, but on the other side, where she should have pain, she doesn't.
Right.
This means that we have a false positive MRI sign.
And now a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to approved medical solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today.
Right? This means that maybe something else is going to be the cause of a pain. And in many cases, it's the fascia. So what I do, I check her knee and I start to, for example, as a reference, I start to push here. Says nothing. Then I come here, and after the second or third, she yells at me or she jumps away. We call that the jump side because it's so painful. And I pushed as hard as I pushed on the other side. So this is for us in glucopuncture. The glucopuncturists know this. This is what we call a positive clinical sign. That's why we say this is patient-guided glucopuncture. We also have ultrasound-guided glucopuncture, but image-guided. But this one's really like my hands and her expression. From human being to human being. I'm not looking at the screen of a machine. I'm looking at my patient. So I start to push here. And, oh, yes. And you know what I'm going to do. I'm going to inject quite superficially 5 or 10 cc of the dextrose 5% solution. And I say to her, come back next week. It is there for 6 months or 6 years. You'll have to maybe come 4, 5, 6, or even 10 sessions. If it's recent and less serious, as in her case, it was rather serious on the MRI. But after, I think it was 4 or 5 sessions, they came in both with a smile because his shoulder pain was gone. They said, I'm so happy I brought my wife because she stopped all her medication already. And we have still 2 weeks to go before we have the operation scheduled. And now we are thinking about postponing it. And I only gave her injections this deep, right? No danger. I can do it with eyes closed, literally. So easy, not painful, no local anesthetics added, no steroids, of course, just dextrose 5% or glucose 5%. That's it. And if you, as a physician, experience that in your office once or twice or 3 times, then you say, I have to look at this again because nobody told me about it. Right. And this seems to work. My patients tell me they don't lie. They're not, let's say, working for a pharmaceutical company and pretending it's good. No. They're really sort of giving you a nice testimony. Right. So we have here what we call false positive and false negative signs on MRI. Right. You know, and you have them as well. A patient has pain, certainly getting pain in the right. And MRI says hernia L4, L5 on the right side. Go to the orthopedic surgeon or the spine surgeon. Okay, you will be scheduled for next week when we're going to take away the hernia, right? This happens every day in Belgium. I think it's worldwide. Right. If I see a patient out there, and I published one with Professor Long, by the way, of pseudo sciatica, that patient had several trigger points. The one I remember very well was the one on the sacroiliac ligament, and that you don't see on animal. Right. But when I pushed on it, I said, oh my God, don't push so hard because this pain is really awful. And it goes into my leg. And that patient also had trigger point in the gluteus muscles. Same story. So I never touched the back, only the ligaments and the muscles in the sacroiliac area and the gluteal area. And I can't say by heart, but it was like maybe 5, 6, or 7 sessions. And the pseudosciatic pain was simply gone. Again, false positive results of the MRI because the hernia is still gone today as we speak. Right. And the operation would not be successful. No, that's because the pain origin was in the sacroiliac ligament and in the gluteal muscles, the trigger points over there. And that is what we call the functional diagnosis. We have the conventional diagnosis, which is very important when you want to exclude cancer or something very serious. You don't want to treat that with the glucopuncture. Then in that case, I take it for my own protection. I take an MRI of the back or whatever it is, just to be sure. Right. But I don't treat the images. I treat the patient sitting in front of me, and my hands are going to help me. And that is so beautiful, so rewarding, and interesting for doctors in low-income areas because they don't have access to MRI or the patient can't pay for it, can't afford it.
Right.
So that's why we try to get the glucopuncture first in certain low-income countries or low-income areas. And then I think it will come back to the rest of the world. I hope so. That other doctors are trying to think, oh my God, I don't always have to go deep. I don't have to always go for sensory for an operation. And the same with the knee you talked about.
Right.
Elbows, shoulders, name it. Yes.
Well, let me add something to that because it reinforces your statement about how patients are very accurate about finding their point of pain or the origin site. Now, one of the things we take care of a lot of superficial perineal nerve entrapments, and it's a difficult nerve because it has a high degree of variability. So in one patient, it can branch one way, another, and so we're always trying to plan our incisional approach. And one of the things that we discovered maybe 10 years ago is that if we would lightly palpate down the anterior lateral aspect of their leg, their lower leg, and we would tell us where it's most tender. And it would be a very light palpation. And they'd say, oh, right there. And we would mark the X. And when we would operate, the nerve was entrapped. It was within 1 centimeter of that X all of the time. And it was so incredible how accurate these patients are. So they really will be able to tell you better than an MRI
exactly
where their pain is. And the reason I say better than an MRI is because an MRI really only evaluates objective morphology. A tissue is either disrupted or not disrupted. And then you have to make the jump from, okay, I have a tissue that looks abnormal here. Is this the pain generator? And a lot of times it's just said yes, for example, the low back. I mean, everybody's running around with low back pain right now, but that's not the genesis of all of their lower extremity pain. They can have coexistent back pain and peripheral pain, but they will tell you if you just do what you just said, palpate lightly, have them tell you where that spot is. It's pretty amazing.
I would add to this, and I thank you for your comments. I would add to this, we in glucopuncturists, we have learned again to watch and feel the patient lie on your table. Because in the old days, my father was a family physician, but I'm talking about the 70s or the 80s, they didn't have MRI yet. X-rays was all they had, and they had in general practice, so to speak, and a bit of ultrasound. But they were still focused on the physical examination. But with all this new ultrasound and CT scan and MRI and all the rest, doctors are more looking at their screen of the computer or of the ultrasound machine that they're looking and listening to the patient. And there is so much information lying on your table, sitting in front of you. They say, oh, when I do like this, I have pain there. What does that mean? It means there's something with the rotation, maybe a ligament, maybe a muscle. Then I say, where do you have pain? They say, it's here. Where exactly? Here? Okay, I start to examine. I'm always the first, even if I've seen 5 physicians before me, to do that. It takes me 15 seconds, not so much time. And then suddenly, yes, that's the one. Yes, doctor, that's the one. And of course, I have already my signature to the 5% in my health. And I will inject right away because I don't want to lose the point. I even don't use a marker. I do it right away. I'm right-handed, but I'll use my left hand to look for these points. And immediately with my right hand, 1 injection, maybe 2, sometimes also around it. For example, this morning, she comes for the first time, a nurse. And she has pain in the foot sole on the right side. I still see her this morning. And she goes, this is for years. I've tried several different things because she works in a hospital. Nothing works. Foot soles, medication, you name it. And at some point, the doctor says, I want to give you a steroid shot into your heel. I said, I don't want that. She's a bit more very reluctant about it. And that's how she came to see me. And the funny thing is, she lies on my table. I said to her, maybe your pain in your heel is referred from more proximal. We call it referred pain patterns, right? And I said to her, I'm going to examine not your heel, not your foot sole. I'm going to I'm going to examine your calf muscles or your calf and look for pain points there. And there I have a strategy. I start with the superficial ones, where I look for the exit point of nerve and also, of course, on the fascia, which is for me something very like a wonderful idea. And if that doesn't give anything, then I'll push deeper for the muscle trigger points. But for her, I use the pressure which goes like half a centimeter, that is like a quarter of an inch deep, and already said, oh my God, this is painful. Her body moved while I pushed on the points. And I said to her, I'm going to start with these points, these fascial trigger points that I found. That's what we call them in the calf. I haven't seen her again yet, of course. I will see her next week. But I'm like maybe 50 to 80% sure that after a few sessions, without touching her heel, without injecting her foot, she will say, I'm walking much better. But she has difficulty walking, especially in the morning. The first steps are horrible. She can't walk like 500 meters. She can't walk for a few minutes. She can't. And she's like maybe in her 30s. And so she's really desperate. And I can't say, I'm not sure, but the chances are very high that with superficial injections into what we call the origin zone, that we will treat the calf and that the pain in the heel and in the foot will be better. And and I've had many of those. And that is, you feel so happy. I think it's having a few of those photographs or images in my book here that, for example, here, but maybe you won't see it. Well, it's a guy that has pain in his shoulder and arm, and I inject in the infraspinatus area, but it doesn't have anything. And yet there again, you can inject into the fascia or deeper into the infraspinatus muscle, or both. Right. So we have these three layers: fascia, the most important one today; the second one, the muscles, still very important; the third one, the ligaments; the fourth, which we use a lot, of course, is joint injections. I published one article of a patient in his early 60s with a frozen shoulder. And as a test, I gave only joint injections, which worked well. But we now, these days, also combine it with fascia of the shoulder and the muscle trigger points around. So there is infinite possibilities. But you just have to understand the basics, then use your hands, and you build up experience with your hands and with your injections.
Right. Now, that brings me to one point from a diagnostic standpoint. When you talk about joints in the peripheral nerve world, we're always trying to figure out what's extra-articular versus intra-articular. And one of the great ways to make a pretty accurate diagnosis, whether it's inside the joint or outside the joint, is to very simply put some lidocaine only inside the joint. Don't infiltrate any subcutaneously bone right into the joint. You put a couple of cc's into that joint, regardless of what joint. Give it a few minutes and then ask them how much their pain has resolved. If it's solely coming from inside the joint, usually what they'll say is, all my pain is gone. But if it's extra-articular, their pain is still there. They may say they're a little bit better, but that's another way to add on to that diagnosis. If you're feeling a little bit like you want a little bit more, this might help you just a little bit.
That's absolutely correct, yes. And I think my approach is that I'm so sort of enthusiastic about injecting the fascia of the last years, especially it has been exploding, so to speak. Right. That, what I do anyway, without doing your local anesthetic test, I do the fascia anyway. It's never going to hurt anyone. Right. And if after 2 or 3 sessions they say, oh, my pain is much better, I don't have to inject the joint. If they say it's like maybe 20% better, then I will, in the second, third, or fourth joint, I will inject the joint. Again, with the dextrose. Why not? Right.
What's been your...
Combine both.
Jan, what's been your experience with intra-articular D5W injections? Has it been one, or do they need a series? What's your experience with that?
I don't use them that often. Okay. I use it mainly for frozen shoulder. Then I have the most experience with joint injections. And I tend even there to go a little bit higher than the 5% to have more sugar water into that joint. Because you can find in one of my references the 3 major effects of dextrose to the joint cartilage. There are 3, but I can't tell them by heart now. But that's one point. For the knee, same shoulder and knee. These are easy joints to inject. Rightly, no problem. Right. And see them more as a second choice. I'm so in love with the pain points and the trigger points in the fascia and the muscles also. For example, knee joint pain.
Right.
Okay. And the patient points, let's say this is my knee, to the front of the patella and the patella tendon. It said, here's my pain. Okay. I start to examine that area. I don't find anything. Superficially, nothing. Around the tendon, I find nothing. Then I go upstairs, we go to the area just above the knee, the quadriceps muscle, where is also fascia, of course. And then sometimes you find awful trigger points or pain points there. Then I will start to inject those because it could be what we call reverse pain.
Right.
And you can combine it still with the joint injection of dextrose. And you can also see maybe the pain is coming from the hip. Maybe the pain is coming from the fascial artery if it's on the lateral side.
Right.
Maybe it's coming from the adductor muscles on the medial side. Maybe there are some nerves on the medial side which also are, let's say, neurogenic, and that you can inject that as well. You can even treat the low back if that's necessary. It could be coming from the sacroiliac ligament and so forth. But the basics would be starting like, do you really have pain only here, or do you also have pain over there? That's for us a simple question, which guides immediately. Do we have to focus on the local and check it maybe into the joint? Like in the frozen shoulder, I have the tendency to inject in the joint all the time for real frozen shoulder.
So do you think that you're getting an additional benefit? Let's use frozen shoulder as an example. If it's, if everything's bound down and tight, then you know that the fascia around it is affected negatively. Of course. So by introducing something like D5W intra-articularly, does it maybe shut down pain enough intra-articularly for a period of time that they can start moving the shoulder? Or
in that case, I use the very high volumes, 10 cc, even 20 if it's an adult grown-up man. So smaller patients up to 10. 10 cc gives expansion of the shoulder capsule from inside out.
Okay.
And there is a study about this, but they didn't use the dextrose. They used, I think, sodium chloride or something. And only by giving a large volume of a neutral product, already the joint capsule could sort of, relax, so to speak. And then I use dextrose because then I have the volume effect and I have the dextrose effect. And the article that I've written in for the European Society of Medicine here, and it's published not on PubMed, but you can find it online. And there I used with that particular patient, 10 cc, it was a grown-up man, like maybe, a normal grown-up man, so like 1.80 m, normal weight, not some 190. So I admit that's just because you don't want to inject too much because you might explode the joint capsule, right?
Right.
So you start with 5 cc, no problem. Next time, 10 cc. And in this guy, I even injected 20, which is a lot. Okay, you need a special, I think, a 4 centimeter surge of a 26 or 25 gene. And you inject it slowly. It's no lidocaine, no procaine. It's not painful if you do it slowly.
Right.
And you start each session, you give a bit more, 5, 10, 15, 20, and the joint capsule will expand because of the volume effect. And then, of course, because you inject a lot of dextrose, you also have the dextrose effect. So you have both. But I would also recommend, as if you're a bit experienced, to combine all this with extracapsular injections. The capsule insert from the outside, but also the fascia, the muscle, the pectoral muscle on the front, the infraspinatus on the back, the deltoid muscle on the side, and so forth. So then I would usually give a sort of combination. But the patient that I published was only the joint injection.
That's very interesting. That was going to be my next question. When you do the intra-articular, are you also hitting the extra-articular at the same time? I mean, it's not an academic experience here. We're not trying to have control arms of the study. We just want to get this patient better. And so,
exactly.
So do everything you possibly can, especially if you got
the more,
right.
Yes.
Yeah.
The more layers you have, the more effect you will have clinically. But I published it with only the joint injection, And I really wrote at the end, I'm publishing this to invite the medical researchers to do the same in a longer series with maybe 20 or 30 patients and maybe do some testing before and after, just with that to see if that is really working. Because if you do inter-articular, the fascia and muscle trigger points, you don't know which one has worked.
Right.
So from the scientific point of view, you have to cut it into pieces. But a patient sitting in front of me, suppose you are sitting in front of me, said, I have a frozen shoulder, I can't do this, I can't do that. Then I will give you the joint injection for sure. And we start with 5 cc, but I will go up each wing with more volume. And I will also look for the pain point in front here, on the side and on the back, and inject these. It's superficial. It will be the fascia. It's a bit deeper. For example, the infraspinatus muscle is very important. The pectoral muscle is important. There you have to be careful not to inject too deep, of course. But
Right.
if you know your anatomy, you can do this very easily. And then I have maximum results.
Say that again. What was the last? I didn't hear the last
Then
one.
when you combine several layers,
Yeah.
you maximize your clinical outcome, your results, your
Right.
maximum results.
Right. What's been your experience with glucopuncture? And we're going to talk about fascia, but I'm going to go a little tangential now. What's been your experience with neuropathic patients?
Oh my God, neuropathic.
Yeah.
I had a few beautiful ones. I also had my failures. Don't think that everything is working. I'm not a god, and I'm not everything, and all the time it's working. But I'm so enthusiastic. And neuropathic pain, I published one which is on the PubMed, published by Couriers about 1 year or 1 year and a half ago, for a lady in her late 80s. She came to see me for several months, maybe even years, from time to time for knee joint pain and a shoulder pain and neck pain. And she has a private nurse who's also a driver and so forth. And she called me or sent me a mail and said, this lady, Simone is her first name, she can't come because she has awful pains on her side. And that's why we come on the couple. Say, what's going on? Oh, she had a zona, a herpes zoster infection, correct?
Right.
At first she had the skin lesions, but afterwards, for months, I think it was 5 months, but you can look it up online, and neuropathic pain in that area. The skin was almost normal, and awful pains. Our cousin was a nephrologist in a hospital nearby. She went out, they sent her to the pain clinic, as we call it here. They gave her medication and tried everything, nothing worked. That's what, and I said to the nurse and the driver, please bring her here. Bring Simone to me, because this is something that I would love to treat. She comes to see me. All she does is say, here is my pain. It was not in the arm, it was in the side, next on her, under her shoulder, so to speak, on the left side. And what I did now, that's what we call glucopuncture specifically for neuropathic pain. We give intracutaneous injections. So the injection is also like the fascia, but and also tangential. But instead of injecting under the skin, we inject into the skin, and you create a white spot, like they call it in German, they call it a bottle. It's like a mosquito bite. It's the injections themselves are the pain, very painful, and you give like 10, 20, or as much as you can of small of those injections. I have it somewhere, yeah, because I think she's also in the book, but you will find it online. And let me see if we can spell. Well, this is an example of multiple injections, but maybe you can't see it on the.
Can you move it back just a little bit? I think you're scrambled.
Don't worry.
That's okay.
Intracutaneous injections. You can find this publication on PubMed. You just type my surname and last name, and they will see treatment of post-therapeutic neuralgia. Listen carefully. After she had it for months, and all the pains. After 5 sessions, no more pain. The first session didn't help at all. The second, she looked at me and something is happening. I don't know what, but I took less medication. And the nurse said, yes. And she's more like friendly and more happy, less like depressed because of the pain. And after 5 sessions, and we speak now, maybe a year ago, no relapse, only intracutaneous injections. Anyone can do this.
Sure.
Safe, but it's a bit painful. That's all. So I've done this once and twice. I only had maybe one failure, and that was a patient from the area who said, I have much more pain and a lot of stress. He has a lot of problems with her children and previous husband and whatever. And that's the only one where I didn't have success. I had another one who had pain here, also postherpetic neuralgia, here in the face and the eye. I only injected here and there into the cutaneous after 2 sessions.
Gone. Yep.
Gone.
Yeah.
So am I lucky? Maybe. So I invite my colleagues worldwide. That's why I published this. Please do this again or do this as well. And test me. Check me out.
Right.
I don't know if it's working for everyone. Let's find out. Maybe it only works with old people, or maybe it works only with male and not with the female. We don't know. We have to find out. But that's why.
I think the point you're making is very valid, because you're not asking someone to do something that has a very minimal benefit over adverse effect. You have something that has an extremely wide safety profile that you're really not going to hurt anyone with. If you have just even a modicum of knowledge of where you're putting this solution. So the risk is very minimal, and I think that people should be encouraged. Yeah, that people should be encouraged, because they've reached out to me like, where can I learn this? And, I point them to your book, the link online and everything like that. But my comment to them is just start doing it, and you're not going to hurt someone with it. And
exactly.
And then so what if you only get 60% results? Well, that's 60 out of 100 people that got.
That's still a lot.
Yeah,
that's still
beautiful. A lot. Yeah, absolutely. Of course, we want everybody 100%. That's the way we're wired. But
of course we want.
It's just not that way sometimes. But now there's something you point out in your article, the most recent article, talking about how most people do not have any pain after the administration of a glucopuncture. But there are some people that will get, what was the term you called it?
We call it the reaction phase. And I explain it this way to my patients. And it's good for doctors to know, if you have a fresh injury, like an athlete with a muscle tear, or a recent inflammation of a tendon or a joint capsule, a twisting the ankle, whatever, an ankle sprain, then you don't have reaction phases, and you have almost immediate results after 1 or 2 sessions, and gone. You don't see them again until they have sprained their ankle again. Things will better here, for example. But then you have other type of people coming to see you, here to other patients, and they have pain for 6 months or even 5 years. And then I say to the patients, think about an lasagna. It has 7 layers. The first layer was when it started. You had an accident 7 years ago, and I don't know, you hurt your knee. Then it didn't got resolved, and the tissues around it, fascia, tendon, joint capsule, all started to deteriorate, right? Because of the chronicity, it becomes like several layers, metaphorically speaking. 7 layers are all, let's say, dysfunctional. So I start with the last, I don't know all the, I start with the last one, and the superficial layer may come out, and they have it for 5 years, and after 1 or 2 sessions, they say, it's already better. I say, wait a minute, we're not finished yet. You have this for 5 years, there's still something to come. And when I touch the next layer, which is maybe a muscle or a tendon, which is very hard or whatever, and I'm going to inject my Dextrose 5% there, then you may have what we call a reaction phase. And what is a reaction phase? In fact, it's a positive sign for the doctor, but it's negative for the patient. It's positive for the doctor. Why? Because the doctor knows that the body is starting to repair connective tissue. Because glucose, we know it's very good for repair connective tissue. But the patient in that moment, or the day after the injection, has more pain or even more stiffness. And then, especially when we inject fascia, the pain area can move. So they have, for example, pain in the elbow, and they say after 2 sessions, the pain is going down, and more in the direction of the wrist, and they are a bit confused. And I'm so happy. I say, it's starting to move. That's the integrity of the fascia we were talking about in the beginning. It's so connected.
Right.
They can have some shoulder pain while you're injecting a golfer's elbow because they're all interconnected. And then it follows the size of my patient. So it's important that patients know that if it's worse the next day, it's not even not a bad sign, but a good sign. The body tries to recover, tries to repair things. So I really say to my patients, I'm not trying to sweep the dust under the carpet. We are just doing the opposite. We're pulling the carpet up. You blow, the gas comes up. It looks worse, but afterwards it will be better. What you do with steroids and painkillers, you put more dust under the carpet, you cover it up, you put a strap around it, and it looks clean. But underneath, it's not okay. And the body has a capacity to repair itself. And we are just guiding it or stimulating it. And the body does the rest. The glucose is just like, I would sometimes say the ATP from the glucose is like an energy, a recharge of the batteries of the cells in the time, right? Which is probable, true as well. So the cells start to function better. So connective tissue becomes more supple. That's what we see with Dupuytren patients. Dupuytren has nothing to do with pain. They have hard parts here. I had one also published in Korea. That's the second one I have on PubMed. And the patient, it was a great one. This is an easy one. And so far, we only have been successful in that. We don't know why yet, but he has two types of these hard nodules here. I don't know, I can't say by heart, but you can look it up. I've injected him a few times. I've taken photographs, even video. And now, after 4, 5, 6, even if you watch it, I can't find it. She knows his hand very well because he massaged it for years already. And it's just gone. So, and this is also the opposite of prolotherapy. I think it's interesting because some people still use the old sort of prolotherapy for dextrose 5%, which is not correct.
Right.
Prolotherapy comes from Hackett and Hempel, right? We go back more than 5 decades in the United States. And they use first phenol, afterwards sodium moderate, and then dextrose 15, 20, or 25%.
Right.
If you use the dextrose of 15 or let's say 20%, you will have an hyperosmolar solution in the extracellular matrix. What's happening? The cells implode. They have cell destruction.
Right.
This is 100% scientifically proven. And this creates, this is our foreign bodies for the extracellular matrix. What are these cellules doing in mass soup, so to speak? They should be inside the cell, not outside. So the body said something is going wrong there, and then have a reaction on that, and that creates connective tissue proliferation. That's why we say prolotherapy. That's where it's coming from. So you have a sprained ankle, and the ankle is like this. Use prolotherapy, much better than glucopuncture. Right. But if you have the Dupuytren, it's the opposite, because if you use hypertonic solution, it will only get thicker. That's not what you want. So for Dupuytren, and I've used it several times, we use the glucose or the dextrose 5%. And in some cases, not always, I had some failures, I must admit, we see that the nodules become softer and even sometimes disappear. And not a few very spectacular ones, but not always. So it's important that we realize that glucopuncture is something completely new. That's why I use a new term. Because I was using because of the Koreans, 5%. And when, you know Patterson. I've been to Patterson's course for prolotherapy. I've read the books. I have the here of Hackett and Hempel and all of the other prolotherapy books. It's a completely different game. But now, because of that, they both use dextrose. They mix it up.
Right. You have to be careful.
Make the distinction.
You have to be careful with your nomenclature because they're not.
I know.
Right. So exactly. Let me ask you. Are you combining your glucopuncture with any modalities like mobilization after they come in to, like, let's say, a frozen shoulder, so that you can try to stack some beneficial things together for these patients? Tell us about that.
Yes. Well, let's say that first of all, you have to see what we're talking about. An athlete comes in and has a sprain of his left calf muscle, right?
Right.
I inject him twice that week, on Monday and on Thursday, with the dextrose 5%, with the glucopuncture. and everything is gone, and the next week starts playing again. Normally should be making between 3 and 6 weeks. I had a hockey player who was playing like high level, and she came twice. She's from South America, but she lives in Belgium. And she came twice, and then was in touch with our physiotherapist. He insists physiotherapist techniques, muscle training, whatever. But the glucopuncture sort of halved the recuperation time, which was normally 6 weeks. She would be back on the field at 3 weeks. So we try always to combine it with osteopathic techniques, exercises, muscle training, posture training, and so forth. It depends. For example, neuropathic pain after herpes zoster, no physiotherapeutic measure, just the glucopuncture. But if you have a whiplash, and I inject the glucal ligament, which is a very important one for whiplash and glucopuncture after a trauma like a car accident, then I would say go to a physiotherapist, do your training, have him done manipulation if necessary, because we help each other.
Right.
If we both understand that the body has the capacity to repair itself constantly, we're doing it right now while we're sitting here, the body's constantly repairing things, and we stimulate that with the glucopuncture, and the osteopath or the physical therapist understands that we are a great team. Really can work together. He or she is helping me, and the glucopuncture is helping them. So it's like a win-win situation. We work as a team. It's like a carriage with two horses, and it's going to win anyway.
Yeah.
Yes.
No, totally agree. So how do we get folks to find you? Where do they go online? So because they're going to have a lot of questions. I'm going to encourage them to get your book, which is they can just download it. And
it's an ebook. Yes.
Yes, an ebook. It's a great little book. So tell us how the folks can get in touch with you.
Well, let's say that I have a page. It's just the very beginning of Glucopuncture on Facebook. It's just the beginning. I didn't have much time so far, but I also have a few of my articles that I publish on my Instagram account. That's just Jan Kersschot. It's my name. The other one is called Glucopuncture, and I try to publish as much as I can online. And if you go to the glucopuncture.com website, but I have to sort of renew that one as well, because I've been spending so much time on the new course that I neglected a little bit. I will work on it very soon. Then they already can find some references. And if they type online and go to PubMed, they find soon.com. And most of these articles, as you maybe have experienced, give some background about the history of glucopuncture, what's the difference with the prolotherapy. You can combine both in some cases, because it might be, I also practice prolotherapy. I also still practice some neurotherapy and support. Why not? So in certain cases, the prolotherapy is better than the glucopuncture. In some cases, the procaine is also better than the glucopuncture. I do several techniques, but we are focusing on now on glucopuncture because it's the newest one. And in my opinion, the best one. But let's say patients, they have to look for someone who's doing it, and that's going to be difficult because it's a very young treatment. I hope to change it. So we have now 7 doctors in Indonesia and Russia doing it. We are looking for Africa, but it's going very slowly. In Europe, it's also going very slow, but it might change, for example, with guys like you, ebook and so forth, and so my glucopuncture course, then they can follow it and easily learn it in a very, because I have about 100 videos and 300 slides with clinical examples, photographs. I mean, it becomes really easy to work. Yes.
Fantastic. Well, Dr. Jan Kerschot, it is always a pleasure, an honor for me to have you on the show. I always learn so much from you, and I really love what you're doing. So have a great...
I appreciate also, yes, and also very grateful to you and helping us in this project. And we also hope that we can spread this in these low-income countries, because they need it even more than the Europeans and the Americans, by the way.
Well, see, I might argue with you there a little bit. I do see the great benefits for the areas that are more impoverished than others, but I actually think that this is so important for everyone just because of what we talked about. That, patients should not look at this as like, oh, this is the cheap option
No,
Actually, it's the better option that happens to be less expensive, and that's the important point.
That's very correct. It's good that you adjust my what I just said. And in my office, the glucopuncture comes first. And if that is not successful, it is only in a small percentage of cases, then I will send them for MRI and I will suggest operation or even neuropathic stimulant or whatever it is. But mine is the glucopuncture is the first choice. And sometimes doctors send patients to me and say, how is it possible? We are working on this for years. They've been seeing 3 hospitals. And after 5 times going to see you with your sugar water, they sometimes laugh at it, but they don't care anymore. They're just better. They're playing tennis again.
Right.
So that's good news.
Well, we could say that the sugar water is the new snake oil.
Okay.
All right. Have a great rest of your day. Thanks so much. I know we're going to be on here again in another few months talking more.
Oh, yes, for sure.
All right. Have a great one. Thanks.
Thank you so much. Take care.
This episode is sponsored by Savant Sellers, providers of boutique Tier 1 Reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Sellers. You may just never want to come out until it's gone. Savant Sellers sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at savantsellers.com. That is CEVANT sellers.com. Spelunk15.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, potofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.